So we can proceed for another other speaker. It's from Dr. Junaid Babar, again from the General Hospital, Lahore. He's going to talk about the dealing with the uncrossable lesions, a challenge case. Dr. Junaid Babar.
Bismillahirrahmanirrahim. The topic for today's case is dealing with an uncrossable lesion, always a challenge. Starting with case presentation, a 62 years old female with diabetes, hypertension and progressive skeletal myopathy presented with recurrent chest heaviness. Her ECG was unremarkable. Troponin I was done, which was raised. She had normal renal and LV functions. Her diagnostic coronary angiography was carried out. You can see that the left main and left circumflex is normal and heavily calcified non-obstructed LAD. RCA was heavily calcified with critical mid-stenosis. So we decided to proceed with PCI to RCA with rotational atherectomy via the 7 French femoral axis and 7 French JR guiding catheter. We tried to cross the lesion with BMW wire, even with the support of microcatheter caravel. As you can see that there was some malalignment of the guiding catheter, which also causing hindrance in the wire manipulation. So we changed the guiding catheter to extra backup RCA 6 French, and the pilot 50 guide wire was placed in distal vessel over the microcatheter support with very difficulty. Next step was to exchange the wire to rota wire over the microcatheter, however it wouldn't cross the lesion. So what are the next options? We took 1.0 into 15 mm sapphire balloon to dilate the lesion to facilitate the microcatheter advancement, but the balloon couldn't cross the lesion. So microcatheter couldn't cross, 1.0 balloon couldn't cross, rota wire was extremely unlikely to cross directly. So what are the next options? I'm sharing the algorithm to approach the balloon uncrossable lesion. First line is to use a small balloon or rupture the balloon in the vessel, which is the granuloplasty. Second line, to increase the support by changing the guiding catheter and the wires. Third line is to use a microcatheter, wire cutting or puncture. Fourth line is the use of laser and atherectomy. Fifth line is the subintimal technique, which include the external crush or distal anchor. So this is a pictorial demonstration of a talkable microcatheter, which is a turnpike in this case, that how it works. Toxicity and highly stenotic lesions causing hindrance in the catheter advancement. So the torque generated at the hub of the catheter is transmitted down the shaft to create a rotation at the tip. So constant rotational movements keeps on facilitation of the catheter through the stenotic part. As you can see that the torqueable microcatheter, which is the turnpike in this case, causing the facilitation of delivery of the microcatheter in the distal vessel. So the pilot 50 wire was removed and exchanged to rota floppy wire. And later on 1.5 mm rota burr was done at the speed of 150,000 rotations per minute. Later on the polish run was done. We required multiple shots of atherectomy due to transient blocks and ST segment elevations with each run. We had a minophyline in hand for intracoronary bolus, wasn't required. This is the demonstration that how the ST segment elevation and various degree of blocks with each rota run. This is the post atherectomy shot. We took 3.0 into 12 mm NC balloon at 14 atmospheric pressure, which got burst due to heavy calcium. So we took another balloon of 2.75 into 12 mm non-compliant balloon, which also got burst. Then we took 3.5 into 24 mm Promus Premier stent and deployed it at 14 atmospheric pressure. We took another 3.5 into 24 millimeters Promus Premier's overlapping distal stent and deployed it at 16 atmospheric pressure. Post-dilatation was done with non-compliant balloon of 4 into 9 mm along with the whole length of the stents. These were the final results with good expansion. So we need to plan our cases carefully, consider worst case scenarios and make plans to counter them. Dealing with calcified vessels often requires specialized tools and techniques. Torqueable microcatheters can be handy and a good choice in such case. Thank you so much.
Very nice presentation, Junaid, again. I want comments by the panelists about the case, heavily
One
calcified
of the
vessels.
options you can use is extra support wire. Sometime it helps because it remains straight. It may help, it may not, but it may help sometime, yeah.
Okay, all right.
Another thing which you can do to increase the guide support, there was a marginal branch, you can anchor your balloon there and increase the guide support.
So any audience comment from the audience? Do you have any comment regarding the case? It's a very nicely done case.
I have got a question.
Yeah.
Okay. My first question is, which turnpike did you use? Number 2, did you do IVUS to this patient? Number 3, in this case, where was the calcium, right? Why not IVL was the best choice? How could you remove a calcium within a stent? I think calcium would be behind the stent. So it's my question. IVL shouldn't have been the best option in this case. So all of these three. ELCA, I mean.
I'm Dr. Ahmed Mukit. I was supervising this case with Dr. Junaid. And regarding the questions, I was 1.0, even 1.0 into 15 balloon was not crossing. And IVUS was highly unlikely to cross in this case beforehand. Obviously, it can be done after the stenting for further correction and further imaging, guided further processing of the stenting. What was the second question? IVL. Yes, IVL was not available at that moment when we did.
Yeah, that basically what were you ablating with the rota? Was it calcium?
Yes, it was calcium. There was no
calcium
stent
was
beforehand.
coming through the struts into the lumen of the. I don't think so that the calcium was coming
No.
through
This
the
was not a
struts
case of ISR. This was a case of heavy calcium inside the vessel as well as extrinsic calcification, as was visualized in the LAD. LAD was unobstructed, but there was heavy calcium. It was visible on the first angiogram. It was not a case of ISR.
Sir, one question. Sir, excellent case. My question is that your microcatheter was not crossing. Did you try AL guide because it is more supportive?
Which guide?
AL guide.
Yes. It could have been tried. We took ultimately we took XBRCA. The rotation atherectomy was done with the XBRCA, extra backup. That was the best guide available for extra support.
You have used the turnpipe in this case. You have rotated it clockwise or anti-clockwise or both. How much movement you will give to push it down? You see?
I mean, normally it's 3 turns, leave, 3 turns, leave, because it goes to 3 and then comes back. But it's not advisable to do too many.
You should go clockwise and anti-clockwise and push
Turnpike
it like
is
that.
anti-clock, Corsair is clockwise. And for fine crash, you can go either way. Turnpike is you. It was gold, LP, which one? Which turnpike did you use? Actually, gold is the best for calcified in these vessels. So, it was simple turnpike. Okay.
Thank you very much, Dr. Junaid.